Hello, everyone, and welcome back to another exciting episode of MedSynapse podcast series, where we decode innovations in medicine with leading experts. Today, we are diving into a less talked but a game changing topic, which is interventions in men's health, prostate artery embolization, or PAE, a minimally invasive procedure offering relief to patients with benign prostatic hyperplasia or BPI. And to walk us through this incredible technique, we have with us Dr. Amol Bhalekar, an interventional radiologist with a strong academic background, MBBS from NDA MVP Medical College, followed by an MD in radiology from prestigious KM Hospital and State GS Medical College. He is deeply involved in performing advanced interventions in radiology with a focus of precision and patient's outcome. So, welcome to the show, Doctor, and thank you for joining me to for this incredible discussion today.
Thank you, Etri, for having me on your podcast with MedSynapse. I'm really thankful to all of you for giving me this opportunity.
Thank you, Doctor, and we're excited to hear your thoughts on this topic. So, Doctor, to begin with, could you walk us briefly through your journey and what drew your focus towards interventional radiology and procedures like PAE?
I started my journey in 2003 when I joined KEM as a radiology resident, and KEM being the place where interventional radiology has been practiced for so many years, and it has been a center for excellence, center for teaching. I got an opportunity to learn interventional radiology from stalwarts like Dr. Ravi sir, Dr. Hemant Deshmukh sir, Dr. Kranti Kumar Rathod, and I could pursue a career in interventional radiology. I'm very fortunate that I could learn this field and provide my services to the patients.
Such an inspiring story, Doctor. Now, Doctor, let's now get into the nuts and bolts of PAE. Can you describe the technical procedures, like how exactly is it performed and what imaging modalities guide you throughout the procedure?
So, Hetvi, I can just start with prostate artery embolization as a procedure started in the 2000s, and this is a fairly new procedure, but it has been widely gaining access now that it has been proven efficient to manage benign prostatic hyperplasia, which basically means a prostatic enlargement that happens in almost all elderly individuals, elderly males, and that causes urinary symptoms. That causes urinary symptoms in the form of decreased urination, less flow, difficulty, pain during maturation, and all kinds of symptoms related to the lower urinary tract symptoms. So this procedure intends to provide relief of symptoms to the patient in a minimally invasive or non-invasive way, where the patients can go home after treatment the same day. They can be treated with local anesthesia, so they are awake during the procedure. And even now that we have gone ahead, we are treating the patients through the hand. So the patients actually feel really comfortable during the procedure, and within 2 or 3 days, their symptoms are actually starting to relieve. Within a week, they get complete relief, and the size reduction in the prostate happens over a few weeks. It continues up to 6 weeks. These symptom relief lasts up to 10 years, and fairly most of the patients would be really not needing any interventions later on. The procedure also has an advantage that it provides less risk to the patient, as in the form of infections or pain or any discomfort that happens post surgery. This procedure actually gives them quite a symptom relief with a minimally invasive way with less of risk factors. And to describe on the procedure, we basically enter a vascular access. We do a access from the femoral artery or through the radial artery. Once we have done that, we do an angiogram of the abdomen, and we go and cannulate or super selectively cannulate the prostatic artery, which actually supplies the prostate. There are usually two prostatic arteries, each on either side. And once you have done that, with a very small catheter, almost a 2.2 French or 2.7 French catheter, we are able to inject few particles, and the prostate blood supply is decreased. This causes the prostate to shrink in size. The procedure gets over within a few minutes, and the patient can be going home within a few hours. on the same day.
Yeah, I think that's so impressive to know that how precision actually, really enables such targeted therapy with minimal invasiveness. Also, it's really interesting to know.
You asked about the imaging modalities that you are using.
Yes,
So we basically use an ultrasound to diagnose the prostate. We diagnose the prostate by the size and we calculate the volume. We try to calculate the pre-void and post-void urine. And from that, we know whether the prostate is really significantly enlarged. If it is so, then we can go for further investigations. Usually, we do a blood workup, a urine routine microscopy, and we do a PSA level, and we try to identify the cause for the enlargement. We try to identify if there are any other causes for those lower urinary tract symptoms like a urethral stricture or a vesical calculus, which can also give rise to similar symptoms. Once we have identified it's just the prostate and we plan that, okay, now we are going to embolize the prostate, we are going to do the procedure in the cath lab. The cath lab is basically a fluoroscopy procedure where we actually do the angiogram on a digital subtractive angiography. That basically means we just see the vessels and we can cannulate those selectively. Sometimes before the procedure, we usually do a MDCT angiogram to understand the anatomy of the prostatic arteries. Prostate being a small organ, it has usually, as I described earlier, it was two prostatic artery, one on each side. There are some anatomical variations that we see, and we should, if we identify them prior to the procedure, it is easy for us to do the procedure at the time of the procedure. And of course, it helps in predicting the success of the procedure.
yes, correct. Doctor. So now, doctor, there has been some buzz, especially among urologists, regarding the learning curve and anatomical variations involved in PAE. So, in your clinical practice, how challenging is this procedure, and what are the main anatomical pitfalls you keen an eye out for?
So, as you know, the prostate has been the realm of urology treatments, and
Yes,
benign prostatic hyperplasia has been treated with TURP surgeries for quite some time, and they have been
correct.
fairly successful at the treatment, except for the fact that there have been some post procedure symptoms that usually the patient has to deal with, particularly urinary dribbling, sexual incontinence, and things like that, sometimes infections. Of course, there is blood loss that happens during the surgery. So, prostatic artery embolization actually does away with all these things that can happen with the TURP, and it gives an advantage over that. But for the anatomical learning, because I said it's a new procedure, it started 2000s, and now that we have come almost 20 years into it, I would say that the prostatic artery anatomy has been fairly well studied and well described. And we come across still cases where these are elderly patients. There is atherosclerotic disease involving the pelvic vessels or the vessels in the lower abdomen as well, and where it might be difficult to cannulate. But it is not impossible given that our hardware, that the catheters and wires have developed so much that we have 1.5 French microcatheter available, smaller particles, smaller wires, and of course it can be a challenge for a technical challenge, but it is not impossible to do the treatment. And of course, and it's just like an angiography, so you did not do everything on the first day. You can plan the case, you can do an angiogram, you can study the anatomy, plan your case using the right hardware, and in that case you will be able to get good technical success for the prostate. There are few arteries which are nearby to the prostate, which is like the artery to the urinary bladder, like the vesical arteries, artery to the lower rectum, the inferior rectal artery, and then there are arteries supplying the gonads. So these are the vessels which are actually very nearby to the prostatic artery, and there are collaterals that exist. Collaterals meaning to say anatomical connections between the vessels. So to deal with that, we need to have a very good DSA, digital subtraction angiogram. And once you are able to have that by doing a selective cannulation, you can avoid non-target embolization, which has been described earlier, which actually lead to some symptoms like rectal ulcers and vesical necrosis and things like that. But I don't think that that is a problem now. It has been as you go ahead, the technology and the procedure becomes fairly more easy. The people who are learning the procedure now have actually learned from the experiences of the previous doctors, and therefore the procedure today is quite safe.
Right. I think that's very insightful. So thank you for sharing that, doctor. So now, doctor, my next question would be like, are there particular patients or patient profiles or comorbidities where PAE proves especially beneficial, or any scenarios where it is contradicted?
I can tell you patient stories which will help you understand on which type of patients will benefit more. For example,
Yeah.
patients who are taking anticoagulation, antiplatelets, who
Mm-hmm.
have some heart condition, who are having some, for some reason, they cannot stop their anticoagulation. In that case, an angiogram can be easily done. We have closure devices available. And even with the anticoagulation, we can do the prostatic artery embolization where the surgery may not be possible. Similarly, patients with low ejection fraction, where anesthesia might be a risk, and as a cardiac risk, they cannot have a surgery. For them, prostatic artery embolization is a fairly safe procedure because we are going to use just local anesthesia. Similarly, to patients who have severe respiratory disease, COPD, I have had a patient where the saturation on room air was less than 70, and patient was on O2 support even at his home. We were able to do the prostatic artery embolization and he got relief from his prostatic symptoms. And it was all done under local anesthesia without any risk. With a saturation of 70, I don't think that any anesthetist would give a general anesthesia or any kind of ventilator support to the chronic COPD patient. Similar patient profile might exist. Younger patients where they want sexual function to be preserved, which is really important for them. For them also, this procedure is quite beneficial because the sphincter and the gonadal arteries are actually spared during the procedure. So it is just the prostate that we are going to embolize, and it actually helps them retain their function, avoid the post-operative urinary dribbling, and things like that.
Depend on patient's history, and the treatment should be tailored according to the patient's history, right?
Surely. There might be a patient who might have urethral stricture, I said, or who
Mm.
had a vesical calculus, in which case they might go for a TRP or a surgical treatment because any which way the patient is going to have a surgical treatment for the calculus or stricture, and where the prostatic artery embolization only we may not help. And those might be the patients where the surgery might be helpful because they can get cured for the same procedure.
Definitely. Yes. So now, doctor, finally, for the physicians tuning into this episode today who are considering referring their BPH patients for PAE, what sort of baseline evaluation or workups would you recommend that they complete before referring to an interventional radiologist?
Whenever we have a prostate patient coming to our OPD or clinic, we would discuss with them their symptoms first and associated comorbidities. Considering all that, when we are planning the procedure, we would do a basic workup, which includes blood workup, like it's a complete blood count, uh, renal function test, uh, viral markers, and we would do a urine routine microscopy examination for sure to understand if there is any urinary tract infection that the patient already has. If so, the patient has to be treated for the urinary tract infection before doing any kind of procedure. Also, we would like to know the PSA levels. The prostate specific antigen is an investigation, a blood test where we know whether the patient has a risk for prostatic cancer. If that is raised, we have to work him up for a prostatic malignancy where we may have to do a MRI of the prostate prior to deciding on further treatment, or the patient may need a prostatic biopsy, which we do with a transrectal ultrasound guided biopsy. And in that case, if it is required, then we go ahead and do that.
It is actually incredibly helpful that every actionable insights for our listeners to take away from this episode. So thank you so much for sharing that with us today, doctor. And we're actually very grateful for your insights today. So thank you for sharing that and joining us today, doctor.
Thank you, Hetri. Thank you, MedSynapse, for giving me
Yeah.
the opportunity.
Thank you, doctor. And to our listeners, stay tuned for more such conversations on MedSynapse. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay curious and keep learning.